So teamwork and communication, I feel like, are these two major underliers of everything that we do in the operating room. And transfer, transport, positioning, major teamwork involved. Seriously important to have good, clear communication. So definitely two big themes that just, are threaded throughout everything that we do. So anyways, having said that, I found this little video. I hope that you enjoy it. It made me laugh out loud, so hopefully it will you too. I don't know, maybe it's just my weird sense of humor, but I think that is definitely applicable, right? I mean, in the operating room, how important is that for us to just be very direct and very clear and get clarification, right? As we are a patient advocate, right? And so when we are moving patients from place to place, direct, clear communication with clarification is extremely important. What say you? What are your thoughts? Did that bring up anything? Did you find it humorous? No comments?
It was cute. And sometimes it's just simply a matter of asking the question.
Right? It's just about asking the question. You're absolutely right. I always say, well, if you don't ask, then the answer is always no, right? Or you have no new awareness or perspective. So, the worst they can say is no when you ask, right? I mean, the worst the bear could have said was no, but at least the rabbit would have tried.
I feel like that really is the absolute worst the bear could have, because, yeah, for the poor rabbit.
Yeah, right? Or he could have said, I'll give you a head start running. I mean, at least there would have been some sort of option, or, well, maybe there was a quid pro quo, that could have come out of it, like you scratch my back, I'll scratch yours kind of thing. I don't know, but again, we don't know unless we ask, right? All right, I'm going to pull up the PowerPoint for today. Let's see here, here we go. All righty. Lots of good information in here, hopefully. Let me arrange you guys so I can see you in the chat and everything else. Okay, so moving, handling, and positioning. I'm just going to talk about the moving and handling. So the book goes over a lot of things that we should consider and think about when we are transporting a patient, positioning a patient, those kinds of things, transferring. And one of those big things is just to kind of think forward to what the risks might be, right? And then how we, work towards preventing those things, identify what could go wrong, and have set solutions in place for those things already. I had an experience in my past when I was working in Tucson at the surgery center where about 3 months after performing or after helping out with a breast biopsy, it came to our attention that there was a patient that was suing, I guess, the facility because of an injury she sustained during surgery, which was like an injury to her shoulder. We didn't work on her shoulder. We did a breast biopsy. However, 3 months later, how much do you think we remembered about that particular patient? I didn't remember anything. I did hundreds of biopsies at that facility, but they brought in the entire team that had participated in that procedure. And, we started talking about identifying potential risks or potential situations that could have occurred, see if it would trigger anything in our memory. Like, was there a situation where you were moving one of the patients and their arm, fell or wasn't controlled, or was positioned greater than 90, or whatever the case may be. So there's definitely those situations where those things occur, but we couldn't think of anything. And I don't think it ever went further than that, as far as I know. But those are the situations that we're faced with where you don't really sometimes identify a specific situation that happens, but then later on, long time later on, there's a situation that occurs. So I think my point being is that awareness when we're in the operating room of if there's any little thing that does occur, that we bring it to somebody's attention, we document it properly, address it, whatever the case may be. Like, well, the arm did slip a little bit. I think it was okay, but whatever. So knowing the risks is important. Protecting patient identity, that's a big one, right? So the book talks about ways to identify the patient, and we always want to use 2 pieces of information. Every patient will have like a medical ID number. We can use that. We can use their birth date. When we, if we're the ones that's asking them to verify that information, we don't want to give them the answers, right? Okay, Roberta Smith, you're having your gallbladder out today, right? Better to say, can you tell me what your name is and what procedure you're having today, right? And then we can verify that. So we always want to make sure that we have the right patient, we're doing the right procedure on the right part to the right person. It's always an important thing. And, years ago when I started doing this, there was no such thing as a timeout. We didn't do timeouts. We just brought the patient in, did the surgery, right? There wasn't any real set process, like pretty much all hospitals now have like this patient safety checklist or something like that they use, where, it's very methodical and process driven, the things that we do before we poke, cut, or do anything, insert anything into a patient, right? The teamwork aspect of it, of course, is significant. And we want to make sure that as we're doing these procedures, we know the safety mechanics of it, and that we communicate and we have enough people to do the job and all of those things. What's the temperature in the OR? Do you guys remember?
65 degrees.
Yeah, that's cold. That's cold, right? Especially when you're in there in your nothings, right? So, just making sure that we cover the patient as good as we can. If we're not in the sterile role, then we can assist with that with warm blankets or whatever the case may be. But we don't want them to be any more exposed than they have to be. Wrong site surgeries still occur. Unfortunately, not that long ago in Rhode Island, don't have surgery in Rhode Island. There was a series of wrong site surgeries. I've also seen situations where it is scheduled on the OR schedule incorrectly. It says right whatever, and it is actually a left. So don't just trust that the surgery schedule is correct. What you want to do is, if it's a specific side, you want to make sure that you confirm that with your circulating nurse when he or she comes back from seeing the patient, right? Because you're going to open your stuff together, nurse and you, and maybe some other helpers, and the nurse is going to go see the patient. So, they're going to make sure the patient is NPO. Actually, they'll probably do that before you open, because it's kind of wasteful if the patient isn't there and NPO before you open. It's going to be a waste of things. But they have a checklist of things that they're going to do, and one of the things is to check and verify what surgery they're having, right? So when the nurse comes back, you need to verify, this is the right side, correct? Or this is the left side, correct? And then you need to be watchful too, because I can remember an incident where we had a resident that was helping out with, she was following one of our podiatrists, and I was finished setting up my case, so I was just hanging out, and I saw her go to put the tourniquet on the wrong leg. And it's kind of confusing, right? When you're standing at the feet of the patient and your left is their right and their right is your left. And so that's kind of confusing. And she picked up the foot, and they typically put it against their chest, put the tourniquet on the upper calf. And so the nurse glanced over at me and I waved her over, and I said, whispered to her, she's putting the tourniquet on the wrong leg. She's like, oh. So she goes over and she tells her, and so she already had some padding on the leg, and so she takes that off. Well, the nurse goes back to doing whatever, and I'll be darned if the resident didn't pick up the same wrong leg a second time. So make sure that you are honed in on that, because I've also seen a surgeon go to inject the wrong foot before, because in podiatry, we don't prep and drape prior to injection. They inject first. So pay attention to those things to make sure that, it's a team effort to make sure that we are doing the correct procedure on the correct patient. Questions, comments about that?
It just makes me think of the stories that I've heard, from other friends of mine that are surgeons or doctors or what have you, where they've gone in and, the patient's there and they've drawn on their knee, this knee, and on the other one is not this knee. So I think it's kind of funny that people are aware that these situations happen, and some people are kind of funny about it and take it into their own hands just to make sure. Maybe that needs to be a practice in Rhode Island.
I think it does need to be. We've done those things in facilities that I've worked at too, where they'll give the patient a marker in pre-op, and they'll write yes on the operative side and no on the non-operative side. One of my favorite podiatrists, Dr. Mott, his last name M-O-T-T, they at the surgery center would have the surgeon initial where the patient wrote yes. And his initial looked like not. So at some point they were like, look, you maybe write your first name, because every single time we look at this, it looks like not. And but yeah, we did those practices too, had the patient identify and then the surgeon verified with their initials. So you know, patient identification, it's a big thing. I also had a situation where I wasn't in the case, but there was a patient that had come in for a total hip revision. Now, when you do a primary total hip, left and right does not apply. All of the components are the same. Whether it's a left or whether it's a right, you just got to find the correct size. But for a revision, they put a longer stem into the femur, and the right one is curved a little bit, and so is the left. And so those are side specific. And those implants have to be ordered special. And the way the story went was the rep for the company looked through the window and saw the patient was right side down and left side up, consequently, and went and checked the OR schedule, and the OR schedule said right hip revision. So then he checked with the team. It was indeed a left. The patient was asleep, and they did not have the correct implants. So that was they still did the surgery. They had to hustle to get it was 45 minutes for there's like a FedEx like runner that had to get the implants and deliver them. So yeah, those kinds of things are a must, that we just checks and balances so that we make sure we're doing the right thing. And then explaining the process to the patient. I mean, if you're performing a procedure on a patient that is awake, then we need to explain what we're doing to them. So here's some things we're going to talk about. Transporting versus transferring. So always good to remember good body mechanics. Even when we're standing at the field just working, we want to make sure that our feet are a little more than hip distance apart, so we have a good foundation. You know, if we are lifting or carrying something, keeping it as close to our body as possible, getting help, knowing when we should ask for help, all of those things, very important. And then it matters as far as the technique that we're using, if the patient is awake or they're not awake. So can they help us or can they not? Transporting, gurney, wheelchair, and then maybe something different for little ones like a crib or a wagon, or the parent might carry the child in, or maybe the nurse might carry the child in, whatever. And then transferring if they're ambulatory, using a wheelchair or a gurney. Okay, moving on. So transport by gurney. How about, just to get some of you guys involved, who wants to, on page 347, read about the side rails? So that first little dot, who wants to read that one?
Side rails are the most basic, effective safety mechanism on the gurney. They must be raised at all times when transporting the patient. As soon as the patient has been moved to a gurney, the rails must be raised. The locking mechanism may lock into position automatically, one-handed operation, or require the operator to pull and release the locking mechanism, requires both hands. Always ensure that the patient's hands and arms are well clear of the side rail before raising or lowering it.
Thank you. Yes, side rails are extremely important. You know, when we move the patient, when we get the patient into the OR and we get them up next to the OR table, those side rails are going to come down. And at that point, we need to make sure that somebody is always beside the gurney with the patient so that we make sure that they're safe. Thanks, Ian. All right, who wants to read the next one? Intravenous hanger positioned at the footy.
I'll read. It says, the IV hanger pole is always positioned at the foot of the gurney to prevent patient head injury. The hanger may be raised or lowered in height, and some models can be folded into the frame of the gurney when not in use. Some gurneys have a lock mechanism to remove the hanger completely.
Yes, indeed. I do see them put it at the head quite frequently. Even though this says put it at the foot, a lot of times we do put it at the head. And so having said that, we just need to be cognizant that it's secured properly for transport for sure. And typically, you know, we'll move all of that stuff over before we move the patient over, right? IV is going to get moved over and all of that fun stuff. Then, you know, then we'll have them move over. And it always seems as though when we get to the point where we're going to need the patient to move, like they just want to move immediately, right? So it's important for us to say, okay, like keep all arms and legs inside the vehicle until it's come to a complete stop, and then don't go anywhere until we tell you to. Yeah, thank you, Ariana. Very good. Who wants to read about safety straps? Safety straps.
I'll do it.
Thank you.
The safety strap is placed 2 to 3 inches above the patient's knees on top of the blanket or sheet. It is secured with 3 finger space between the patient and the strap.
Thank you, Jonathan. I've never seen a safety strap on a gurney. I don't know. Maybe I just haven't worked at places that are safe. I don't know. But we do always use safety straps at the OR table. And it's the same principle like I showed you in lab. I just want to make sure that you know, we keep that on the patient at all times as soon as they move on to the OR table, and then we don't want to take it off until right at the time that we're going to have them move back onto the gurney. Good, thank you so much. What about oxygen tank cradles?
I'll read
I
it.
can do it.
Thank you.
Oh, go ahead, Wendy.
A cradle or rack fitted for carrying oxygen is located at the bottom of the gurney between the wheels. The tank should not be placed alongside the patient on the mattress where it may cause injury or roll off the gurney.
Yes, thank you so much. Yeah, a lot of times they want to put it at the patient's feet. And that's not the best place to put it. You can see here, this is a ICU bed, but you can see how the oxygen canister is at the foot, and it has a special holder there for it. So we don't want it to injure our patient in any way. Very good. Rainey, do you want to do the next one?
Sure. So the 4-wheel brake mechanism. Modern transport gurneys have 4-wheel brakes to ensure safety while the gurney is parked. The brakes are operated by a foot pedal located at the side bottom or front bottom of the gurney. The brakes must be engaged anytime the gurney is at rest.
Yes, thank you so much. Do you guys all remember the locking mechanism on our gurney at school? It's the red, right, on that green-red pedal. So anytime that we're not moving, we want to make sure it's locked so that the patient doesn't sustain any injury. And if you're like taking a gurney to the floor to help somebody pick up a patient, which isn't a uncommon or unusual thing, you know, you always want to make sure it's locked before that patient moves from their hospital bed over onto the gurney. Yeah, good job. Thank you. What about 3-phase pedal operation?
I'll read it.
Thank you.
3-phase pedal operation, neutral Brake and steer, figure 18.2b. Most gurneys have a three-phase lock and steer mechanism built into the pedal in neutral position. All four wheels turn freely in this position. In brake position, the wheels are locked and will not roll. In steer position, all four wheels are in the forward position and will not turn.
Excellent. So thank you. So like we talked about in class, if you're by yourself, then it's best to have it in the steer position. And if you have somebody else with you, then the neutral position is going to be better. But if you're by yourself in the neutral position, it's going to be really hard to kind of navigate that by yourself. Good, thank you. All right, what about hand grips?
Okay.
Thank you.
Hand grips for the operator. Hand grips are used to steer and maneuver the gurney. If possible, avoid using the side rails when pushing or pulling the gurney, as they may suddenly disengage.
Yes, very good. Thank you. Yeah, and our gurney doesn't really have that. It just has kind of that bar at the top, but a lot of them that you see will have these little handles that come out like this that are near the head, and that's what you will push from instead of those side rails. Very good. Thank you. The next one is adjust upper body and full body Trendelenburg tilt. What is that about? Who wants to read that?
I can read it.
Thank you.
The head of the gurney can be raised hydraulically or by using a manual handle according to the needs of the patient and the situation. The gurney bed can also be tilted to Trendelenburg. The whole body is tilted head down, or reverse Trendelenburg.
Yep, you got it. Trendelenburg. Good job.
Position for emergency situations.
Yes, very good. Thank you. So remember on our gurney, the two small pedals that I said, if you step on them at the same time, the bed will go down. But if you step on the one that's closer to the feet, the foot of the bed will go down, which is reverse Trendelenburg. And then if you step on the one that's closer to the head side, then the head will go down, which is called Trendelenburg. And we not only is this useful for when the patient is on the gurney, it's also used for positioning in surgery as well. So if we have a good example of reverse Trendelenburg is used for laparoscopic cholecystectomies because gravity will help us gain access to the gallbladder. If you put the patient's head up and their feet down, then abdominal contents moves south, and then we tilt them a little bit to the left, and so it shifts the abdominal contents down and away from liver and gallbladder. Conversely, if we want to use Trendelenburg, some times when we might use that is during a hysterectomy. Gravity will help us as well during a hysterectomy. When we have head down, is going to shift abdominal contents towards the head and away from the uterus. So we can use those positions to let gravity assist us in our exposure for different procedures as well. Thank you very much, Tallman. Okay, let's see. Height adjustment. Who wants to read that one? We just have a couple more to go.
I can do it.
Thank you.
Height adjustment. All gurneys are able to be raised and lowered for height adjustment either by hand or using a hydraulic mechanism. When transporting a patient, raise the gurney to the height of your hip.
The height of the hip. Yes. Protect your back, right? And I provided that tip when we were doing catheterization as well. We just want to make sure that we aren't having to put a strain on our body or any additional strain than we have to, right? So that we can work safely and efficiently. So for our gurney, that bigger pedal that we looked at is the one that we would use to raise the gurney. And two, when you're either taking a gurney to pick up a patient on the floor, or you are in the operating room and they're going to be moving on to the OR table, you need to adjust the height of the gurney so that it is at the same height as the bed that they're transferring over onto. Okay. Who wants to read Backboard for Performing CPR?
I'll do it.
Thank you.
All stretchers should have a backboard that is usually stowed under the mattress, or it may double as a removable footboard. The backboard is used to perform chest compressions during CPR when it is placed directly under the patient's upper body.
Thank you very much. Yes, so so two different ways. If it's a footboard that's doubling as the backboard, then the footboard just lifts up and off, and then you would need some peeps to roll the patient while somebody else put that backboard under the torso, just so that you can get that extra support for compressions. So if anything happened during transport, you would have that ability to do that. Thank you very much. Okay, last one, removable mattress with cleanable surfaces.
The patient mattress is completely removable for disinfection between patients. The cover is made of heavy synthetic fabric that can withstand cleaning with low-level disinfectants.
Thank you very much. Yes, so that's an important part of anything that we use in the operating room in healthcare. I remember, and this is a little bit different, but still, I think a similar concept. When I first started working at the hospital in Casa Grande, the patient rooms were carpet. Just think about that for a second. Yeah.
That's right up there with putting carpet in your bathroom. Gross.
That's disgusting.
That's gross.
Yeah. Yeah.
Ugh.
It was like that, what do you like, industrial carpet? I don't know what you would want to call it. I mean, it wasn't like shaggy carpet by any means, but definitely like office type carpeting. It did not smell good at all in there. And maybe it was the carpet, maybe it wasn't, but they have since replaced it all with linoleum. But everything that we use in the in the healthcare industry that's reusable needs to be able to be disinfected, and so the gurney is no different. A couple different things with the ICU bed. So here you see the ICU bed. When you are transporting a patient on a gurney and they're not an ICU patient, somebody can just do that by themselves if they had to, right? We had this little gal at the Casa Grande Hospital. Her name was Darlene. She was no bigger than a minute. And man, she would just transport those patients like nobody's business. She was just a little thing. But man, she was small but mighty. But when a ICU patient is being transported, you need more care providers there when the patient's being transported. So a physician or a registered nurse should be there, and at least 2 other individuals to accompany the patient during that transport. Right? And you can see that there's quite a bit more equipment that they're having to transport as well with the patient, and not just the patient themselves. Thank you, very good. So if we have a patient that is able to move themselves, when we get into the OR, we're gonna lock the bed, we're gonna ask them to move over. When we do that, like I said, as soon as you lower that rail and you're going to lower it before you're going to be in between the gurney and the OR table. And we're going to practice all of this next week. So it'll be fun. And we're going to practice with each other. So it'll be even more fun. So you'll have to lower the rail and then move out from between the two beds, slide it over. And as soon as you get it there, most patients, not you guys, but most patients are going to want to hop over to the OR table. Well, you want to just communicate to them before you even put the guardrail down, the side rail, that, you know, please don't move until we tell you to. Once you get the two beds aligned and locked, you need at least 2 people, but 4 is better, 1 at each compass point, before the patient moves over. Okay, so anesthesia care provider is going to be at the head. There's going to be 1 person to the left of the patient, 1 person to the right of the patient. And if there's somebody to be at the feet, that would be great as well. But a minimum of 2 people. But you really need someone on that far side. So for safety reasons, anyways, once the bed is locked, you know, we always want to remind the patient that the OR table is really narrow. So if I'm ever helping a mobile patient move over onto the OR table, typically tell them, feel the side of the OR table and center yourself on the table. A lot of patients will say, why is the OR table so small? What would you guys say? Or why is it so narrow?
Maybe because I'm only guessing, but I'm thinking there has to be enough space. It's within the field, so there has to be enough space or room that somebody can reach over without breaking that space or like moving their entire body over. It's just like arm's length.
Yeah, I think that's definitely part of it. You know, if you think about whatever bed you have at home, whether it's twin, queen, king, full, whatever, and if you had a patient in the middle of it and you were having to stand at the side, yeah, so the narrowness is for efficiency, you know, just like you're saying, so that we can operate effectively and efficiently without having to kill our backs, first of all, and be able to have better access to the patient. So, you know, if they do ask that, you can just say, you know, it helps to facilitate the procedure, you know, whatever the case may be. Like I said, before we have the patient move over, we want to make sure we move over all their tubes and bags and, you know, all of those things need to be moved over before we have the patient move over. And sometimes, most times, anesthesia has already given the patient a little cocktail. The rumor is that cocktail turns blood in your veins to lead in your butt, if you will. And it's difficult for them to scoot over. Sometimes with the little cocktail on board, you might have to remind them how to do it. Because some of them will just lay there and you're like, okay, move over here. And they're like, look over at you like, you know, and you're like, okay, use your feet, move your butt, I'll help you. And so sometimes we have to remind them of how. Right? Once they have that cocktail on board. So once everything is moved over and it's locked down, you know, as they move over, we want to bring the sheet over with them or their blankets just to provide them with privacy. And, you know, at that point, we want to secure them to the table. I have had patients comment that it feels like they're being crucified, because we do put their arms straight out on arm boards and we strap them down, and we do put a strap across their lap. So I think it's important for us to, if the patient is, you know, coherent enough for us to explain, like, I'm putting a strap over your lap. It's a safety strap. It's to remind you that the bed is really narrow. I'm going to bring your arm out to the side and secure it with a strap, because when you fall asleep, you won't be able to hold it on your own. And so we want to make sure that your arms stay safe and you don't have some kind of injury. So I'm going to secure it out to the side. So that explanation helps them feel hopefully not so weird or uncomfortable. Questions so far? Just a couple little things when we are moving the patient through the hospital. If we're helping with that, we always want to push the patient along in this orientation that you see here. So feet first, so that the patient can see where they're going. The exception to that is when we're getting into the elevator. So we want to use patient elevators and not the public elevators. They're typically bigger. It's easier for them to accommodate a bed like this, and we're not in the way of so much foot traffic. So when we get to the elevator, you want to step inside, you want to hit the door lock, so that it's going to keep the doors open, because it could take you a minute to maneuver the bed inside. And then you want to back in head first, so that when you leave the elevator, you're then again going feet first. Okay, so a couple of things to remember. So two different types of transfer to the OR table. I talked about the mobile one. And so that one's over here. So you can see she's away again. She can scoot over herself, but we still have quite a few people here, at least 3 people, just to make sure that the patient is safe and secure. And then with the assisted, well, this one's over here where the patient might not be able to move themselves, and we're going to practice both. And you guys are going to take turns, whoever's brave enough to ride on the gurney, moving over to the OR table as a mobile lateral transfer, and then pretending like you're a limp noodle for the assisted transfer. Okay, so when we do the assisted transfer here, we want to make sure that there's at least 4 people. One person's going to be at the head. That's typically the anesthesia care provider. And we want to get their go-ahead, right, before we do anything, like we talked about with the catheterization. And then I'm going to show you the device that we use called a transfer board or a roller board. It's one type of device that we can use, but the one that is most commonly used in the OR is the roller board. So I'm going to show you that. But the way that this works is the person that's on this side is going to, if this is where the bed's coming in at, or if over here is where the bed's coming in at, this guy on the far side, on anesthesia's count of 1, 2, 3, somebody's at the feet, and this person is going to hold the torso, and this person's going to control the head. You're going to roll the patient onto their side. The roller board's going to go underneath, and then lay the patient back down in the supine position. And then on anesthesia's count of 3, everybody is going to help to slide the patient back over to the gurney. And so here's that roller board that I promised to show you. It has these little silver rollers inside, and it's covered with this material that's non-porous and easy to clean. This one's just about the length of the torso. They do have ones that are like 6 foot long. These are about 3 or 4 feet long. But this gets placed under the patient, and then that is the assistive transfer device to get the patient over to the OR table or over to the gurney, whatever. Here's the arm board with those straps that we talked about. Here's the safety strap that we saw that we used this week, that we would use, the OR strap. And then there's also other assistive devices like hoists that can be used in on the floor or in the operating room if we have a patient that is like a bariatric patient or something like that, to help us to assist with the lateral transfer. Okay, we're going to take a break here. Let's take 10 minutes. If you could come back a few minutes after 9, I guess it would be like 9:03 would give us a full 10 minutes. So let's do that, and then we'll pick up with wheelchair transport. All right. You're going to pick up where we left off. And we're going to talk about wheelchair transport. Anybody out there ever transported a patient in a wheelchair before?
Yes.
Tell us about it.
Frequently.
Well, in skilled nursing facility, we used it quite a bit. We would get the patient up in the morning, and there were also certain wheelchairs so that we would transport them to showers. We would transport them to the dining room. Usually they had their own, but sometimes we also had patients who used like some of the more complex wheelchairs as well. But yeah, there's a couple of different ways to make sure you're doing it correctly. You know, a couple of different things you need to make sure of. And keeping those foot pedals out of the way is definitely something to watch out for, because that hurts your ankles.
They do, or you're not paying attention and you can smack something with one of them as well. A wall, a doorway.
There have been rub marks on the walls, yes.
Yes, for sure. Thank you. Thank you for sharing. Anybody else?
Wheelchairs are my best friend.
Tell us about some tips and tricks for transporting in a wheelchair.
It's definitely much easier because most of the time, again, those people can usually at least stand, so you don't really have to worry about, it's much easier like on your back, which is the most important. But I mean, it's the easiest of them all. You just kind of, you just push them along. I don't know. I feel like that one's definitely the easiest out of all of them.
For
It's
sure.
very, very easy to get used to.
Easier to maneuver than a gurney or a
Oh,
bed.
definitely.
Yeah.
Yeah.
For sure. Thank you. So Tammy's saying good body mechanics, definitely important for you and the patient, right? If the patient is belligerent, the front wheels, what does Ian say? The front wheels do not lock. Important lesson. That does not apply to STs. Yeah.
It's so something that I actually appreciated about this chapter with transporting is like when I worked in dialysis, none of this was ever talked about per se. So everything you have to learn on the job with properly moving patients. And it took me a long time to realize that it was easier and safer to move a patient like through a doorway backing up rather than going forward and having to reach out and hold the door with my other hand and foot guiding the wheelchair through the archway. But and the one patient, she she was convinced that we brought her out into the lobby so that way when the police showed up, they could bring her out back and shoot her.
Oh my goodness.
And she proceeded to sit in the lobby and tell everyone about how much danger that they were in, and et cetera, et cetera. And it was like, all right, well, you can't sit out in the lobby anymore. Which turned into her saying that we were taking her out of the lobby because we were going to kill her instead.
Oh.
And so she locked the wheels on us. So the front wheels don't lock. That's how we got her out of the lobby. So don't apply that in surgical technology, but fun lesson.
Oh my goodness, that sounds like a crazy time, right? Yeah.
Spit on me.
Ian, I'm glad you mentioned that like you weren't really taught like how to properly like transfer them, because I'm convinced that they don't teach anyone besides like us.
They really don't.
No, the amount of times where like the nurses, they'll be in there to help me like pull them over, most of the time I'm doing like 95% of the work. They're just kind of there.
Or like to add on top of that, dealing with transport services that pick up and drop off patients, and the amount of stuff that with oxygen tanks just being put on their lap, being turned on full blast,
yep,
none of the wheels being locked, et cetera, and it's just like it sounds silly to say, but the amount of stuff that can go wrong with just a wheelchair not being like even properly managed is astounding. You wouldn't think there's as many things that can be wrong with moving somebody in a wheelchair, but there's tons.
Yeah, because there are times where if I leave a wheelchair out of a room, and say the patient is, oriented and they know what they're doing, they see the wheelchair, they're impatient, they'll get up, they'll go and try to just get in it on their own. If it's not locked, then obviously something can go wrong there. And it's just very easy. It's a very simple concept that can go very wrong if not done right.
I think one of the most frustrating things I saw was when somebody would put a patient in a wheelchair or whatnot, and they would have their catheter, the Foley catheter bag, sitting right next to them in the wheelchair. And yeah, they may have emptied it before, but I'm like, no, it has to, there's a hook, you hook it underneath because it has to be lower than there. I was like, oh, it was naughty.
Yeah. Very good point. All very good points. Good discussion. You have something else, Gabe?
Just trust yourself. Don't trust the other people. Make sure, like, if you can't ask them if like the bed's locked, if the stretcher's locked, always make sure yourself, because again, most of them don't really care. They just want to get the patient transferred. So
not that we have trust issues, but we have trust issues.
Exactly.
Yeah.
I trust myself more than I trust them.
And that double check is never a bad thing. And if somebody double checks you, I mean, it's different, but I think it still applies. When I was teaching in Tucson, and the students that were out at clinicals would come back on Fridays, we'd have class or whatever, and it's nice because we get to share their stories and stuff for the week. And one of my students said, I got to do a vaginal hysterectomy. And I'm like, awesome. I'm like, how did that go? And she's like, well, the nurse must have thought I was doing a really good job and really trusting me, because when I initiated my count, she said, no, that's okay. You don't have to count. I trust that you didn't lose anything. I said, this doesn't really sit well with me, because it's not about trust, right? It doesn't have anything to do with your integrity. It has to do with checks and balances and patient advocacy and patient care, right? So, double check someone else, and then don't be upset if somebody double checks you, right? Because it's better twice than none at all. And so, yeah, I like that advice, because we can't be too careful, for sure. Good job. Good discussion. I like it. Some suggestions in the little green box on page 352 that just kind of jumped out at me, and some that you guys already mentioned. Ian said piling things in the patient's lap, like the chart, or Tammy mentioned the catheter bag or oxygen, or whatever the case may be. We don't want to put things in the patient's lap. That's not a good idea. The only thing that should be in the patient's lap is a blanket. And if they have a teddy bear, or a pillow, or I don't know, whatever it is, but we shouldn't use that as a holding place for carrying our items, right? Traveling facing forward, but then Ian mentioned how helpful it is to like go through doors backwards, go into elevators backwards. Also, when you're going down ramps or up ramps, might be a good idea to travel backwards as well. And then just making sure that that wheelchair is locked, because the patients, like Gabe said, patient sees a gurney or a wheelchair, like they just want to leap into it. Like they don't even think, they're like, you know, my chariot has arrived, let's get going. And, you know, that communication even beforehand as you're coming in, just, you know, don't do anything until we tell you to. We're going to make sure that we get everything locked down and safe, and then we'll let you know when it's safe for you to move. Let me see what Rulan is saying. Rulan says, as a CNA, the wheelchair transport was always hard. For me, the footwork, knee in between the patient's leg and watching for cords, the belt used to help them up. Yes, for sure. You know, using that transfer belt, getting them up and into a wheelchair if they're not quite ambulatory or coherent, as we've talked about before. Yeah, they'll run you over, Ian, if you're not careful. Yep. And then those foot pedals. You know, you see these little flip things here, like they need to be flipped up when the patient is getting in. Once they get sat down, you need to put them down. They move out and they move in, and, you know, there's a whole bunch of adjustments. One of the things that I think of is when I worked in labor and delivery was the time in my career where, as a surge tech, I more frequently was using the wheelchair because traditionally as a surge tech, we don't do any of that transporting and stuff and transferring but not transporting. And so we got a call that there was a mama, and she was in the ER, and we need to go pick her up and bring her up to L&D because she is ready to have her babies. And so we grabbed a wheelchair and we went down there. And when we got there, we looked at her and we looked at our wheelchair, and we looked at her and we looked at our wheelchair, and we're like, yeah, no, this wheelchair isn't going to work. So there are situations where there are different sized wheelchairs, and you may need a bigger wheelchair for your patient so that they can be accommodated comfortably. So that's kind of another thing to think of. When we are, you know, and we're not going to use the gait belt where, you know, I'm just going to have you guys, you know, push the wheelchair around, work with it a little bit, but we're not going to do like gait belt transfers and anything like that. There shouldn't really be a time when you're using this. I've never used a gait belt in my entire career, unless you are in like a non-traditional role. So that's not typically, that's not a skill that's recommended by the AST core curriculum. You know, we're not going to use the gait belt, but we'll definitely work with the wheelchair and get to learn its anatomy and those kinds of things. Okay. Questions? Any other questions about the wheelchair transport or comments? Okay. So assisting the ambulatory patient. If you are, for some reason, assisting a patient that's walking to the OR or in pre-op that has to go to the bathroom, I don't know what the case may be. Usually we're scrubbed in and we're doing cases, but in the off chance that you are assisting an ambulatory patient, you want to kind of walk a little bit behind them and to the side. And you can see that this healthcare provider is doing that with this gentleman here. In the case that they are not steady and they go down, you want to be able to control the fall. That is the goal, is to control the fall. And I do not have experience with controlling the fall of somebody that I was walking with, but I do have an experience of a patient falling off the OR table. And that was during a laparoscopic cholecystectomy. So we're taking the gallbladder out. And as I had mentioned before, we put the patient in reverse Trendelenburg, which is feet down, head up. And we tilt the patient to the left. Okay, so that's the positioning for lap chole. And all they have on is that OR strap that I showed you. And so we were doing this lap chole on a Saturday. And the doctor kept asking for anesthesia to tilt the patient a little more to the left, a little more to the left, a little more to the left. I was standing on the left with the surgeon when she started coming off the table, sliding off the table to the left towards us. We had all of our trocars in, we had our cameras and scopes in. She was intubated, she had an IV, the whole 9 yards, draped, we were intraoperative. And so we controlled her fall to the floor. And then that was the easy part, because getting her back up onto the OR table was the really difficult part, since it was a Saturday and there were only 4 of us there. And, but thankfully she didn't get extubated. Her IV didn't get pulled out. And so we were finally able to get her back up onto the OR table. Of course, my field was broken, so I had to go get more drapes and trocars and whatever we were using on the field that was contaminated at the time. I had to run and get, and of course I, break scrub and I run to get the things. And when I come back, my surgeon's already scrubbed and he's like standing there. And I'm like looking at him like, there's only one of me and I gotta open all of this stuff and then I gotta scrub and gown and glove so that I can get you gowned and gloved. And so I just looked at him and he was just standing there. So I'm like, all right. I opened his gown, opened his gloves, and I'm like, if you want to gown and glove yourself, feel free. Otherwise, I'm gonna be a couple minutes. And he just stood there the whole time, never said anything, just kept standing there for about, I don't know, at least 5 minutes, if not 10. So anyways, that's my experience with a controlled fall. So hopefully you guys don't ever have that experience. But you want to try not to support the patient's weight, because you are going to get injured as well, but just ease them to the floor, right? And protect their head. And then call for help. Right? And you want to make sure you don't want to abandon your patient. So once you get them to the floor, you don't want to run to another department to try to find somebody to help you, right? You're going to call out for help. You're going to stay with that patient until, the cavalry arrives, so to speak.
That happened to me when I was doing clinicals for the CNA program.
Yeah.
There was a patient, it was a lady that she literally couldn't get up or anything by herself. And one of the nurse, she stepped outside and she was like literally falling, and I was like holding her, and my back was like how you said, bad positioning. And I was like holding her and I was like, help, help. Cause she was like literally left for more than 5 minutes, and we were going to transfer her to the wheelchair from the bed. So I was like, so I kind of had to report it, and I told my instructor about it. So yeah, I didn't want to get nobody in trouble, but I was literally, my back was hurting the next day, like really bad. And I was scared. I was like, what happened if the patient would have completely like collapsed and hit her head? So yeah, that was the experience that happened with me.
That's really scary. Yeah. And in that situation where it is happening, right? In a traumatic situation, sometimes it's hard to think clearly about the steps, like what you're supposed to do. So yeah, I'm sorry, Robbie.
And just from my own experience with falling patients, unless the patient knows for a fact that they're going down, most of the time, like if you're in a position to catch them as they start to stumble or anything like that, I would say 9 times out of 10 when that happened to me, the patient did everything that they could to prevent falling, to the point where if they did finally fall, it would have been much worse than if they just would have gone down the first time. So I would say just be cognizant of that they're probably going to fight you unless they're absolutely going down. So if anything, like if you're in a position to catch them or support them on their way down, like I would say talk them into going down. It's just like, it's okay, just I got you, you're fine, you're gonna be okay, because nobody wants to fall, whether they're like, from my experience, most of them were geriatric patients, but there were plenty that were bariatric patients or just young kids who were lightheaded or something. But most of the time, they don't want to go down unless it's gonna happen. So if anything, just be cognizant of that and convince them to go down, because it'll be easier that way. But
Great point. I can remember when my mom had her knee replaced, they got her up and walking that night of her surgery that evening. And so they got her up, she had a walker, she was walking, but she was a few steps down the hall, she started saying she was feeling like a little bit lightheaded, a little bit dizzy. And so the care tech that was with her said, just grab that chair and just push it behind her just in case. So one of the nurses saw that, and man, did I get in trouble, because she's like, that is a chair with wheels, that is not safe, you can't push that behind her, if she goes to sit down she's gonna fall. And so I don't know, she had an alternative, I can't remember what, but yeah, something with wheels isn't going to be the best thing to catch a falling patient either. So yeah, that's a good tip, Ian. Thank you so much. Any other questions or comments about assisting the ambulatory patient? Ambulation is key, you know.
I have another one, but it's really nasty, so I don't know if I should say it. It was assisting a patient to the restroom, but he kind of had an accident where he like literally fell, and I had to catch him, but he was using the restroom.
Aww.
Wasn't able to finish, so it kind of went down. And he felt really embarrassed about it, but like I'm like, it's okay, no worries. But he just needed assistance to get to the toilet and then get back up, but I guess he just wasn't done yet, and he was like, oh no, I'm gonna fall, and then I was able to catch him the proper way.
Poor guy. I was teasing Jonathan yesterday about wringing out his socks, but that sounds like that could have really been the case.
So I did clinicals for CNA as well. I had to walk someone over to like where they were like doing physical therapy and stuff. So like, we were moving along, and then she was like, time to go sightseeing. So then like, I guess she forgot that she was walking, because at one point I had her full weight on me.
Oh my gosh.
She was like, I love that tree. I swear, she just completely gave up. Like, and then I was like, yeah, it's a good one. And then she started walking again, and then all of a sudden she was just like, ooh, look, he's eating. And she's just talking about someone else just chilling in the nursing home. I was just like, all right, let's get you over where you need to go. Yeah, it was more fun, only because she was very, very, very light. But anyone who wasn't expecting it probably kind of like fell over or whatever. So I can see why those following the right steps is very beneficial.
Yes, and it's interesting. I was actually looking for some videos yesterday, and I came across one. It's like funny things that people do after they've had anesthesia. And so some of them were pretty funny. Some of them weren't very politically correct, so I decided not to use it. But people do really interesting things when they have a little cocktail on board or when they're waking up from anesthesia. We had one patient, she had broken her hand, and the doctor had put a pin in her hand, and he had planned on taking it out in the office, but the pin had like worked its way like back into like down into the bone, and so shh, be quiet. And so we couldn't get it out, so we brought her to the OR and just gave her a little bit of sleepy medicine, and you know, she was telling the surgeon how cute he was and asking him if he was married, and the whole 9 yards. So it was kind of entertaining. Okay, so transitioning into special patient populations and some things that we should think about with these special patient populations. We're going to look at pediatric patients, disabled patients, bariatric patients, and patients in police custody. So pediatric patients, there's a variety of ways that we can get them to the OR. One way is with some sort of crib on wheels. They have bars. These bars can hurt the child if they get their arm through there and then they can't get it out. And then at one point we used to use like bumper guards, and babies, you know, could get hurt by the bumper guards as well. They could become wedged against them, or they could climb up and try to get over the rail. You can see how this one slides up and down. It locks up. It will lock up into position. Yep. You got it, Ian. And then sometimes we use these little wagons, especially in like at Phoenix Children's or pediatric hospitals, things like that. Or they can be carried back to the operating room by their caregiver, and they'll let the caregiver stay until the baby has anesthesia and they're sleeping, and then, you know, the caregiver can leave, or sometimes the nurse will carry them in as well. So, you know, we've talked about, you know, specifications or specific considerations for pediatric patients before, and this chapter kind of reiterates some of those things. A couple things that jumped out at me was, you know, if the child is unaccompanied, when we separate them from their parents, that's very stressful, and they can have a high level of anxiety because of that. If the child is a little bit older and has an you know, a higher level of understanding, when we talk to them, we just want to make sure that, you know, we're being as truthful but as kind as possible, using small words. You know, I'm not talking to them like they're like we would an adult patient, for sure. And then just to reiterate that they can be quite sprightly, right? So if we don't keep an eye on them, the next thing you know, they could be out of the wagon and running down the hall. So just to keep those things in mind too, if we're transporting them. Questions about that, about PD patients?
Not a question, but I did find it funny when it said, however, remember that toddlers can climb and move with amazing speed and agility.
Yeah.
I was like, absolutely.
Yep. I have that highlighted in my book as well, that little snippet of the sentence. You know, it made me think of my friend Gary when he got the TKO by the 4-year-old, you know, after the tonsillectomy, just like right to the side of the head. So do not underestimate that, for sure. And their superhuman strength. Hearing or sight impaired individuals. When we have these individuals, we want to let them have their assistive devices as long as we possibly can, right? Which we've talked about before. At some point, we're going to have to take their ears or their eyes away, and that is very disorienting. I can't imagine what it would be like to have hearing deficit in both ears. I am completely deaf in my right ear. And that can be very disorienting, just being deaf on one side, because I can't tell where sound is coming from. And, you know, when there was a time when I was living with my parents, and I would tease my mom because I had this big old house. I'm like, Mom, where are you? And she would say, I'm in here. And I'm like, can you just say the room? Like, I don't know where you are. And at the surgery center, one of the nurses that I worked with, her name was Susie. Birds are trying to fly into my window. And Susie was deaf in one ear. She had an acoustic neuroma, and I was deaf in one ear. And when the phone would ring in the OR, there were two of them. The only way we could determine which one was ringing was by looking at the light. And so, you know, it's definitely something that we have to take into consideration with patients that have that deficit. You know, either speaking up a little bit more loudly, or, you know, not putting our mask on until we absolutely have to if it's somebody that is hearing impaired. You know, if we can use hand gestures to communicate for those that are hearing impaired is really helpful. Speaking slowly and being articulate, not using big, gigantic words. Make sure that we're facing them when we talk to them. And then, you know, if we have an individual that's sight impaired, just really beefing up our communication, you know, and just giving the details of what we're going to do to them before we do it to them is really helpful. The bariatric patient. So the bariatric patient, there's a little chart about the BMI index. Obese is greater than 30 BMI, supposedly. There is some conflicting feelings about the BMI index, the body mass index. But care of the obese patient in surgery can be a difficult feat, whether it's positioning them, transporting them, transferring them. All of that stuff can be a little bit more difficult, not to mention intraoperatively. Ariana, I was just reading your comment. Yes, work out. It's good on all fronts for this job because we're on our feet for a long time. We're pushing, pulling, lifting things, leaning over the table. It is a very physically demanding as well as mentally demanding job, career that you're going into. So that's always good. And it's a good outlet as well, right? When we have an individual that is a bariatric patient, we need to have special equipment. We need to have special OR tables. We need to think about positioning devices that are going to be adequate for the patient. We have to recognize that if the patient is laying flat on their back, that they might not be able to breathe as well. And so they may need to be put in this reverse Trendelenburg position like you see on the right here. One of my experiences, not a whole lot of experience with bariatric patients per se. Some hospitals, they have like bariatric surgeons that specifically, you know, do these kinds of procedures. And but one situation that I had experience with was a bariatric patient that was in the ICU and they needed a tracheostomy tube. And so the ICU bed that the patient was on was too big to fit through our OR door. So what we had to do was push the OR table out into the hall, move her onto the OR table, and then push her on the OR table back into the OR. Because typically, when we do tracheostomies in the OR, we just leave them on their ICU beds. We just do it right on the bed. There's too many tubes, wires. It's too much to move the patient. So we just do it right on the bed. So, and that took a little bit of, problem solving and critical thinking to figure out, are we going to have to do this surgery in the hall or how do we get her into the operating room? And so that was our solution that we used. And then we had to do the reverse when we were ready to transport her out of the operating room and back to ICU. We had to push the OR table out into the table, transfer her back onto her ICU bed. So, these patients typically have several comorbidities in addition to whatever they're in the operating room. And so that increases their risk of post-op complications or even death for that matter. Questions and comments about the bariatric patient? Okay, so our last little, the last topic here for us is patient in police custody. When I worked at the Casa Grande Hospital, we're really close to the Eloy Detention Center. And so we had a lot of patients come into the OR that were from the detention center. And a correctional officer would always accompany that patient into the OR. And so we would have to have them dressed in a little bunny suit, like the head to toe onesie, and hat and mask and whole 9 yards. And typically the patient had like a leg cuff to the bed, to the gurney. And so when we would have the patient move over to the bed, then the officer would be there to unlock the handcuff, leg cuff, whatever, so the patient could move over. And then typically they would stand outside the door intraoperatively. I did almost have one of them convinced that I needed to sterilize his gun before he went into the operating room because he couldn't have anything that wasn't sterile in there. And because we decided we'd play this little trick on him. And so I almost had him convinced. He was starting to unzip his bunny suit to get his gun out to give it to me so I could go sterilize it. But yeah, then I was like, no, I'm just kidding. So having an awareness of that, it's probably not the best idea that correctional officer stay in the operating room. I did have one situation where a correctional officer slid down the wall during surgery. So it's probably best, unless we want 2 patients in the same operating room, to just, have them stand outside the door. And then when the surgery's over, and we're getting ready to transport, we can have them come back in and do their thing. But again, that's somebody, a visitor, right, that's coming into the operating room that has no idea what's sterile, what's not, they don't know anything. And so that's in some ways an extra work for us, right? Because we have to keep our eyeballs on them as well. Okay, questions about any of those things? And that's the end of part 1. So next week we will focus on positioning, because it's kind of is a good place to stop, because finishing talking about transport and transfer and all those fun things. So we'll focus specifically on positioning on Wednesday of next week. Okay. What questions or comments do you have? I'm looking forward to lab next week. We're going to do lateral transfer, both mobile and immobile, with the gurney. We will practice with the wheelchair. We're also going to look at supine positioning and lateral positioning. So we'll have a lot to do in our 2-hour meetings that we're together in lab next week. So it shouldn't be boring. We should have enough things to do. So anyways, we'll look at those processes a little more closely on Monday in our LVL. There isn't an LVL for today. It's just your quiz. Now, it won't be open until 11 o'clock. So you will have from now until 11 to just do your reviewing. And then once it opens at 11, go ahead and do your quiz. What do you guys think about corrections? You want to do corrections on this quiz? Okay, so same rules apply as usual for corrections. Just use your Quizlet. That's really the easiest for me. So if you don't mind, that would be great. And if you can just get them to me, you know, in a reasonable amount of time, the next couple days or something, I will accept those. But that's all I have for today. No other bells and whistles. I did look at your feedback from Factile, and for the most part, it was positive that you guys like playing it. One thing that I saw as kind of the common reoccurring thing was that the switching back and forth between Zoom and the other screen. So I'm wondering if you leave your Zoom and then you use your phone as your device for putting in your answers and stuff, then that way it's like Kahoot, right? You have your tablet or your laptop or computer, whatever, to see the Kahoot question, and then you're using your phone as your device to answer. So that might be, instead of trying to do both on your computer. So maybe that might be, that was a suggestion that I thought of. But I think that, and then the pictures being too small. But of course, we don't have to use pictures every time. It was just kind of a thing where we were at, but the pictures weren't very big. So I don't know if that's the images that I used or the just the way that the thing is. So anyways, those were the two biggest complaints, I think. But overall, it seemed like you guys found it to be something fresh and new and interactive and a little bit competitive and a good review. So, so we might use it again in the future. A couple people mentioned playing in teams instead of individually. I cannot figure out how to make that happen, because at first I thought of that and I was like, okay, I'll put them in breakout rooms. But then if I put you in breakout rooms where you can communicate as a group, how are you going to see the screen and answer, and how can I communicate with you? I can't. If I just put you in groups in this open forum, how do you communicate to come to an answer? So if you guys have suggestions of how I could do teams in this virtual environment, that feedback would be great, because I can't at this point figure out how to make that happen. So anyways, something to think about. Anything else for me before I leave you to your own devices? Cheer up, it's Friday, and you're finishing class early. Yay, it's my Friday.
Yay! Are we gonna take the chapter 18 exam on Monday?
No, that will actually come on Wednesday when we finish the chapter.
Perfect. Okay.
Yeah. Yep.
Very cool.
So today all you have to worry about is the minor instrument quiz.
You said 25 questions and it's worth 50 points, correct?
I did say that, yes. And they're all multiple choice.
And it's all it's the basic in chapter 2 in our instrument book, right?
That's correct.
Because that's all I've studied. Okay.
Yep, that's all you need to study. We're gonna start diving into plastics is our next category. Yeah, so if you want to get a head start looking at that, we'll be focusing on those the next couple weeks, and then there'll be a quiz on the plastics instruments. Okay, and as we're in lab, we'll try to look at those more physically, handling them. We're gonna need to beef up our lab time on campus for SUR 120. So I'm working on what that's gonna look like for us. So a lot more skills in SUR 120. So we're just gonna keep ramping it up. So it's pretty fun. I'm excited. Okay, you guys. If you need anything, you know how to get a hold of me. I know you'll do well on your quiz. Have a good weekend. And thanks for all of your hard work. I appreciate you guys. You guys are awesome.
Thanks. Have a good weekend.
Bye. Bye.
Miss Windsor, can I talk to you for a minute?
Yes.
So yesterday I realized I didn't upload my stuff right after lab. I went to work right after class. I uploaded it this morning, so I'll still get the checkoff strike, but then is that marked as an absence?
Let me take a look at it. Yeah, because so you didn't have activity in the Blackboard at all?
No, I don't.
Yeah. Yeah, that's the only thing. Like, we want to have activity in the Blackboard. And you didn't upload your time card either?
No, I didn't upload either until today, this morning.
According to the rules, yes, it would be an absence because there wasn't Blackboard activity. But let me think about it a little bit, and maybe I might pick the brain of somebody else about it. So let me think about that, and then I'll follow up with you, okay?
Okay, sounds good. Thank you.
Thank you.
Have a good weekend.
You too. What's up, Buttercup? You're on mute, lovey.
Son of a nutcracker. Okay. It makes me click twice sometimes, and then I think I got kicked off like at least 7 times this time. I don't know what my internet's problem is, but it just kicks me off and then it brings me back, and I'm like, okay. Oh, you're recording.
Thank you.